Emmanuel and I are delighted to invite you to the annual symposium of the Journal of Cataract and Refractive Surgery, which as usual follows the format of dealing with controversies in cataract and refractive surgery, the format being that there will be arguments in favour of one side of the debate and arguments against, and then there hopefully will be a 10-minute discussion period for the audience to join in and voice their views as well, which will be most helpful. There are microphones in the aisles, so don't hesitate to come forward and air your views when the opportunity arises. The first controversy is excimer laser for hyperopia. What are the age and degree limits? In my practice, I see many problem cases of patients who are in the older age group, more than 50, more than 60, more than 70, and with fair degrees of hyperopia, more than 3 diopters often, who only have problems after laser correction or LVC correction.
Thanks very much, Emmanuel.
So that's the basis of the argument, and I'll hand over to Julian, who I'm sure is going to emphasise that point.
I was just saying thanks very much, Emmanuel. I rest my case. Refractive surgeons, by our very nature, are of course modest individuals, and we don't have much to be modest about because the surgery that we do, procedures with laser refractive surgery, have delivered superb outcomes to patients. But we all have our boundary conditions. We all need to know our limits, both for the safety and also for the happiness of our patients. So what are the age and degree limits of laser refractive surgery? What are the wider limits? When can we reach our boundary conditions and go beyond? We have to remember, of course, primum non nocere, do no harm. Of course, if we followed that completely, you could argue that we should do no surgery at all. There will always be some complications. So we have to have a balance between what is acceptable risk and what is benefit. It's that balance that we have to keep in mind. And this debate will be run and rerun because technology, techniques will continue to improve in the future. Well, let's start at the corneal curvature. The cornea is a curved surface. Water, of course, doesn't like being on a curved surface. It doesn't like being held vertical. So the tear film has stabilizers in it to spread and wet the cornea. But a very steep cornea has a short tear film breakup time, unstable vision. And so there are limits to how curved we can make the cornea. The current consensus is the maximum keratometry should not exceed 48 diopters in the steepest meridian, and some would take the spherical equivalent. Well, let's take a look at how steep can we make the cornea? How curved can we go? There are many, many papers in the literature which basically say you cannot go too steep. Taking a paper by Williams, a fairly recent paper from University of Utah, Salt Lake City. 49 eyes had hyperopic LASIK, 24 eyes had a relatively flat curvature. After treatment, smallish treatments, large treatments, steeper curves. And so, best corrected acuity. One eye out of 24 lost 2 lines of acuity in the lower group, and 10 eyes out of 25 eyes in the higher treatment group. So you are 10 times more likely to lose best corrected acuity for a bigger treatment and with a steep post-surgery keratometry. 10 times. Huge. And if we take satisfaction for the same group of patients, with a scale 1 to 4, 4 is most satisfied, 1 presumably means they're extremely unhappy, and for the lower group, the mean satisfaction was 2.75 out of 4. For the high group, it was 1.52 out of 4. So very, very low. In other words, not a satisfaction score, that's a dissatisfaction score, and statistically significant. Dry eye. Low treatment, as you'd expect, of course, relatively minimal dry eye. On a scale 0 to 3, which is 0.17 mean, whereas with the bigger treatments, 1.84. So effectively, over half the patients had some degree of dry eye, or the severity of dry eye was scored very high out of this group. The American Academy of Ophthalmology, in its guidelines, says post-operative keratometry should exceed 49 diopters to 50 diopters, and if it does, so it should not exceed, and if it does, it's associated with quality of vision problems. So this is a universally recognized issue. What about, is it just the keratometry? I mean, could we take, for instance, the flat cornea of 40 diopters and steepen it up to 48 and successfully get away with a big treatment? Or is it, for instance, if you have a 45 diopter cornea, could you only treat, say, +2? So, another paper by Young and Shalhorn and colleagues reviewed a huge number of eyes as a retrospective review, 1,695 eyes, where they noted that the pre-op sphere is the dominant determinant of visual outcomes. So controlling for pre-op sphere, it's not the final keratometry that's the critical determinant, it's how much treatment is applied. So let's take a look at their results. So what's the proportion of people who lose 2 or more lines of best corrected acuity after hyperopic LASIK? This is with a femtosecond laser and one of the latest excimer laser platforms. With a +4 treatment, 25% of people lost 2 or more lines of acuity. 25%. Whereas with a relatively small treatment, +1 to +2, the results are kicking around just 2%, that sort of level, which is acceptable and is essentially equivalent to our standard myopic LASIK treatments. Well, what about the percentage that achieves 6/6, 1.0 or 20/20 uncorrected acuity for a +4 treatment, which you can see at the bottom line on the screen there? Not even 40% of eyes achieve this. This is why the dissatisfaction was so high in another study, because essentially the patients aren't achieving what they think they're going to get. The surgeons are not delivering, and there's high unpredictability, there's reduced quality of vision, best corrected. That doesn't even indicate the quality of the tear film with rapid tear film breakup time, the unstable vision, the burny eyes, patients interpret as dry eyes. So what about corrected acuity afterwards? Well, again, +4 treatment achieves under 60% that achieves 6/6 at 1.0 corrected acuity. And these are high volume numbers. This is not a small study. This is a very large number of eyes treated. So there's a lot of statistical power in this study. So essentially, the bigger the treatment, the higher the probability of complications, poor visual quality. And optically, that's fully understandable, because when you have a very steep cornea, you've only got to change the radius of curvature in terms of millimeters direct radius of curvature to make a high change in optical effect. So even a few microns of change, because of a fairly small optical zone, will cause a large irregularity, which we can see on wavefront sensing and on corneal topography. So I'm going to show you some images. Well, let's start with topography. You can see here there's a topographic scan, previous hyperopic treatment, and it's decentered, and it's decentered inferiorly. So it looks almost like a keratoconic cornea. And so if you have a hyperopic ablation, then you can have issues if you have decentration. And experienced therapeutic refractive surgeons know that it's relatively easy to fix a myopic decentered treatment with a wavefront guided correction, but treating a hyperopic previously treated eye is a nightmare. One of the other issues is that patients during treatment have great difficulty in fixating. A myo, -3, -5, the fixation target on the excimer laser platform, on all excimer laser platforms, is in focus. You're myopic, you can see the target. Whereas with a hyperope, they're defocused. Quite commonly, high hyperopes have reduced stereopsis, they have convergence or squint issues, they may well be phorias, not tropias, but they often have abnormalities in binocular vision development, and this combined with fixation issues and high angle kappas can be a real issue. And of course, if you have a tilted eye under the excimer laser, you have cosine energy errors, so that one side of the ablation achieves a lot more excimer energy than the other side. This topography clearly shows dropouts, issues. You can't even get a wavefront scan on such an eye. Dry eye, dry spots, even topography is hopeless. What about the maximum age limit? Well, one of the issues with hyperopia is it's often the older person that comes in. You may have a 55-year-old that comes in who's becoming hyperopic, plus 1.5 hyperope. But actually, when you question them, when did you first need reading glasses? Age 45 to 50. And the hyperopia that's developing is relatively recent onset. And looking carefully, it's lenticular in origin. It's a lenticular hyperopization because there's a reduced refraction of light by the lens. So in the older person, you have to look for refractive index change. And the other thing is, after hyperopic LASIK, because of the increase in forward light scatter that we're inducing, because of the optical aberrations, the eye can only cope with a certain amount of forward scatter. So what we're doing is we're committing patients to have much earlier phacosurgery than they otherwise would have done, because they're getting forward scatter from the cornea, and then they get scatter from the lens of the eye. You scatter the scatter, you don't add it, you square it. So essentially, you bring forward the date for phacosurgery. By age 60 years, 60% of us have significant lenticular change anyway. So anyone 60 years and older, and dry eyes, is going to be an issue. So recommendations: treatment no more than 3 diopters, steep pre-op corneas to be avoided, maximum age for phakic eyes, 60 years, caution in over 55 years old, caution with dry eyes. And anyone who treats very, very big treatments and attempts and says they can do that should probably have a drink in this pub near London. Thank you very much.
Thank you, Julian. Now to propose a different aspect to the situation, we have Dan Reinstein going to give another side to the argument. Dan?
Well, thank you for filling a room with 700 ophthalmologists, all who disagree with me at the beginning, and then tilting the conversation and showing that the judge is already bought in favor of the first speaker, who's much taller than me. And that's not because I'm crooked. I'm going to just try over the next 10 minutes to give you a scientific basis for everything that I have done and justify the fact that I'm quite happy in carefully selected patients to treat above +3. I'm going to limit my argument to +4 and above to make the point a little bit more poignant. And of course, I'm a consultant for Carl Zeiss Meditech, and I have patent issue relationships with ArtScan and the Artemis, which is involved in being able to achieve these outcomes. So I'll start off by the outcomes, because I think Julian, summarized certainly the American experience, and we know effectively what laser technology we're talking about for those publications, and so it'll be good. It's good that I put the outcomes first, because before you forget those outcomes, we can go through these. It's a series of 636 consecutive eyes in 371 patients. And we treated hyperopia from +4 to +7.5, mean of over +5, cylinder up to -3, and the age was from 18 to 78 years. Median was 51. Of course, the best corrected visual acuity in hyperopes is often compromised, and 66% of these eyes were 20/20 to start with, just for amblyopic reasons. The enhancement rate is included in the outcomes I'm going to present, and that the total enhancement rate was 25%. But that is because we enhance eyes that are 20/25 or 20/20, or even 20/16 sometimes. And so if we were to consider only eyes that are 20/25 or worse, our enhancement rate would have been 9%. And I also want to add that for treatments above +550, these were planned 2-stage treatments, not 1-stage hits. And I'll explain that in a minute. This is the distribution of hyperopia that we treated. So you see it's slightly geared towards the 4 and 5 diopter, but there's a fair representation at +6 and +7. Here's a scattergram showing an R-squared of 0.677, which is, pretty reasonable. Our nomogram, as you see, 0.96, the linear regression line. Fairly well set. We had 62% of eyes within ½ diopter and 85% of eyes within 1 diopter. If we look at the comparison, between the best corrected visual acuity pre-op and the uncorrected visual acuity post-op, you can see that 59% of eyes were 20/20, but only 70% were 20/20 to start with. So the only fair way of looking at this is, and this is actually the way the patient looks at it, is how do they see without glasses compared to how do they see before surgery with glasses. And if we say reasonably that if they're seeing within 2 lines of what they were seeing with their glasses before surgery, then that would be success. And so it's basically 94% of these patients are able to see within 2 lines of what their glasses were, and some of them better. The monocular efficacy, therefore, if you take it as a percentage of the patients who were 20/20 to start with, was 72% 20/20. And that is about double what was shown for +4 by Julian a few minutes ago. And this is from +4 to +750. Safety is quite different from what Julian just showed. We have 0 eyes losing 2 lines of best corrected, 22% losing 1 line, but remember that there's minification that's coming into play for eyes of this level of hyperopia. And so you have to actually say that it was less than 20% in effect. Contrast sensitivity in these eyes, and I routinely measure contrast sensitivity in all patients, pre-op and 3 and 12 months post-op. There was a drop, which was statistically significant, but it was 0.8 of a patch. And as you know, the reproducibility of this measurement is 1 to 2 patches. And so therefore, we're within the reproducibility of error from 1 week to the next. So this is probably not a clinically significant drop in contrast sensitivity, even though it's statistically significant. Now, if we look at this point, this small drop in contrast sensitivity, I mean, we can clearly see the trend that, of course, the more hyperopia you treat, the more likely you are to lose a little bit of contrast sensitivity. But still, even in the worst case scenario, we're losing 1 patch. The stability, well, this is the stability out to 24 months of this cohort. And I'm going to refer to this a little bit later in more detail. But between 1 year and 2 years, there was a 0.3 diopter shift. And Julian's comment about hyperopic shifts of the lens is very pertinent, and I'll explain that in a minute. In fact, I'm going to explain it now. If you look at Guy Kazarian's publication of 4-year data with the wavelight Allegretto, which is a very similar hyperopic profile to the Mel 80, because it's basically built by the same people, just swapping companies. You see that at 4 years, the mean change between 1 and 4 years in the refraction was 0.19 diopters, and in the keratometry it was only 0.03. So in fact, these changes, as Julian mentioned, are probably taking place inside the eye. So age limits. Well, I mean, I don't think it's a surprise. I mean, if you look at hyperopic LASIK, you'll find that, and this graph shows the percentage of eyes that are 20/20 or better, stratified by age, 40 up to 50, up to 60, up to 70, and above 70. And of course it goes down. But that is also true for myopia. It is just a general fact that corneal refractive surgery works less well in elderly people than it does in younger people. Now, to back up my argument, I'm going to have to go through a bit of history and a bit of technical detail into how it is that we're doing hyperopic LASIK, because I can tell you it is not the same way that Williams and Young were doing hyperopic LASIK at all. First of all, remember that Asclepi and Modetators were the first company to do a hyperopic ablation, and that was in the early 90s. Several companies followed on with hyperopic profiles, and I call those the first generation ablation profiles. The second generation ablation profiles were when the flying spots came in. The Technos 217C did fairly well up to about +3. The Mel 70 did fairly well up to about +450. And then came the third generation, again, a sort of inbreeding thing where Wavelight, Schwind, and Mel 80, they all kind of got the same people programming it. So they ended up with fairly similar profiles. And these people really, these 3 lasers really are in a different category, and they are well apart from the publications that Julian was referring to, as you saw from the outcomes. The wavefront-guided hyperopic concept is an oxymoron, and so if I have time, I'll be willing to explain why that is. Let me give you an example. +4, treated in 1997. He had 88% regression. He had another +350 treatment done. This was done as a PRK. And during the ablation, there was a corneal perforation, which required an immediate corneal transplant, which ended up as a cataract, which ended up with a phaco and a PCIOL. The patient ended up seeing 32 uncorrected. This was published in Ophthalmology. This is another case with the first generation where a +3 treatment regressed 95%, and we didn't know why. This is in the early days of the Artemis, where we could map the flap, we could map the surface of bones, and we found that the intended ablation profile, which would be the green line, the green line was the original cornea. The intended would be as far as the red Bowman's go, and you see the epithelium fills in this gap tremendously. And this is because of the lack of sophistication on the transition zone. Here's an example of a second generation of 217C profile, which was programmed as a 6mm treatment. But by Artemis epithelial thickness mapping, you see the area where the epithelial thickness increased was only 5mm large. So although we were programming 6mm, the optics were at 5mm. And here is an example, more recent, of another 217Z treatment, in which the I don't know, this pointer's not working, I'm afraid. I wish it was, because I could really help you with it. Can someone help me out with the pointer? The first graph is the epithelial thickness of this 217C treatment at, here we are, 5mm. This is an ablation profile. Julian mentioned that it's impossible to recenter or enlarge hyperopic zones. With a topography-guided system, it is actually very easy to do that. And you can see here the epithelial profile now at 7mm post-op, and of course patient's recentration and patient's symptoms cured. So don't get into a procedure that you can't repair, and that's a good idea. ESCRS showed us that with the Bausch & Lomb technology, you get a lot of regression, and you get more and more regression the higher the hyperopia you treat. But David O'Brart with a Schwind showed that at 2 years, there was a stability change of 0.1 diopters from 1 to 2. And on the issue of corneal curvature changes, I would say that there's going to be a paradigm shift of understanding once everybody starts measuring epithelial thickness profiles, because the corneal curvature itself turns out not to be the issue. We all know that the corneal curvature changes as a fraction of the change in refraction, and this has caused a lot of confusion amongst cataract surgeons for IOL calculations. But as far as treatment is concerned, and it has been borne out by what Julian said in 2 ways, the actual amount of central epithelial thinning that occurs is proportional to the amount of hyperopia treated. But the amount of thickening that occurs in the periphery is also proportional to the amount of treatment performed. And of course, it's the difference between these two, which is the way that the epithelium messes up the hyperopic ablation. The point, though, here is this. You may have a post-op maximum that you've set in your mind, but I can show you a case in which someone's keratometry post-op was only 41, and yet their epithelium was 24 microns thin. The breakdown level of epithelium is 21. So if this 41 diopter cornea had had an enhancement, they probably would have ended up with an apical syndrome. On the other hand, here are 2 corneas that are quite steep, and yet one of them has a 45 micron epithelium. Absolutely fine to do a large ablation zone enhancement in a patient like this, because you're not going to cause epithelial breakdown. And as Julian mentioned, water doesn't like to stay on very curved surfaces, but if the rate of change of curvature is very slow, meaning a large optical zone, this isn't as much of an issue. Here's an example of a PRK done with an older generation laser. And you see the apical syndrome, and you see that with an Artemis-guided transepithelial approach, we're able to clear something like this. Does that mean I have to stop?
Well, you've gone 2 minutes over time, and I do want to give the audience
an
opportunity.
I'll just go over the centration issue, because that was brought over by Julian as well. And that is that it has been recommended by many companies that treatment be centered in the center of the pupil, entrance pupil. And of course, the fact that we refract patients perpendicular to their vertex, not perpendicular to their entrance pupil, means that placing the treatment off-center under a laser over the entrance pupil makes no sense. And in fact, vertex centration of hyperopic ablation is critical if you're going to avoid all of those 20, 30, 40% loss of two lines, as shown by Julian. This means you have to center your flaps on the visual axis, and it means that you have to center your ablation. Your tracker has to be locked onto the visual axis, not the center of the pupil. In a study that we are publishing now shows that we got a 0.07 millimeter decentration on average, with a standard deviation of 0.07 millimeters, with the Malady centering on the vertex. And I want to show that this is critical because if you measure the wavefront of a post-op patient complaining of flare after a hyperopic ablation, you see that a wavefront sensor measuring from the center of the pupil measures no coma. But the point spread function calculated from that wavefront from the center does not correspond to the patient's subjective point spread function. Whereas if you calculate the wavefront from the corneal vertex, which you can do from topography, you see that now we do show coma, and now the convoluted image from that wavefront matches exactly the patient's subjective view. So centration must be on the vertex, and it must be done accurately. So in summary, third-generation laser platforms achieve large optical zones and much better transition zones with far less regression. Visual outcomes are actually good, and they are actually compare very favorably with intraocular surgery, if that's the alternative to nothing. Two-stage treatment, of course, is appropriate, and control of epithelial thickness seems to be, well, we believe to be the preferred method rather than keratometry for deciding whether you can do more. Topography-guided treatment is available for correcting aberrations which are induced to excess and which cause problems in patients, and they're very successful at helping these things out. And we published a paper in the June issue of the JRS this year on that. And of course, the epithelial thickness profiles are very important to monitor the progress of these patients and the health of the cornea. And I didn't mention dry eye because I think that it's sort of self-understood that you won't operate on someone with any refractive error on the cornea if they have propensity for a dry eye condition. Thank you.
Thank you, Dan. Dan, are you saying that unless you can measure epithelial thickness, it's not safe to do hyperopic laser?
Well,
No,
I think what I guess if you ask me that way, I would have to go back and find out what it would be safe to do without knowing the epithelial thickness. I can't give you that answer.
Okay, thank you. And to both of you, what is the argument for doing refractive lens exchange for the high probe over 55 years of age? It seems to me if you're going to do a hyperopic laser in a 60-year-old, then you've got to think about 55-year-olds who soon will be 60 years old. But there seems an argument, which I know wasn't part of your remit, to consider, but I think you have to answer whether refractive lens exchange is a more logical intervention for the motivated high probe. Julian?
Well, my argument is that lens implants offer better quality vision, more predictability, almost an instantaneous result, and it's a lifelong retention of that vision. You don't have the dry eye that will occur with the high hyperopic treatments, regardless of the optical zones or epithelial thickness or any other measurements that's made. The dry eye is part and parcel of the laser refractive, cutting a flap and so forth. I think lens implants are the answer for the higher hyperopes. No,
and it does retain the cornea for fine-tuning.
Exactly.
Dan, what would you say?
Well, I would just put up a slide and show that the accuracy of refractive lens exchange in hyperopia is not better than that between +4 and +7, the way I'm doing it. I would also say that the efficacy is not better. And I would also say that there is a tremendous advantage to treating plus on the cornea, because at the time that, first of all, you don't have to go inside the eye.
Dan, John, I'm just going to challenge you about the accuracy.
Can I finish my sentence?
Go forward. Well, you've got over a 1 diopter standard deviation on the higher hyperopes, whereas with lens surgery, the standard deviation, at least in my hands and is published, is 0.6 diopters with biometry.
I do want to give you
Well, I've got a slide up here which I suggest.